Good afternoon and welcome. I'm Dr. Margaret Greenwood Erickson. I am one of the first-year fellows in the National Clinician Scholars Program here at IHPI, and it's my pleasure to introduce Dr. Abdul El-Sayed today. Dr. El-Sayed is a public health physician and epidemiologist. He serves the City of Detroit under Mayor Duggan as health officer and executive director of the Detroit Health Department. Appointed in August of 2015, Dr. El-Sayed is responsible for rebuilding the city's health department after it was privatized in 2012 during Detroit's municipal bankruptcy. In his first year, the Detroit Health Department more than doubled in size, and city support for public health increased fivefold. The department has emerged as a state and national leader in public health innovation, environmental justice, and lead elimination, earning Director's Award recognition from the Michigan Department of Health and Human Services in 2016 for its work screening water in Detroit schools for lead. At the department, Dr. El-Sayed's focus has been on major initiatives to reduce infant mortality, to promote vision access, and to integrate early childhood services. During his tenure, the department has secured competitive funding from multiple granting sources, ranging from the McGregor Foundation to the Michigan Department of Health and Human Services. In his role as Detroit's top health official, Dr. El-Sayed also serves on several public health boards, including the Governor's Childhood Lead Elimination Board, created in the wake of the Flint water crisis, as well as the advisory committee to the U.S. Secretary of Health and Human Services to inform the forthcoming Healthy People 2030 objectives. Dr. El-Sayed is an internationally recognized expert in health policy, the social determinants of health, and health inequalities. Previously, he was assistant professor at the Department of Epidemiology at Columbia University, where he directed the Columbia University System Science Program in Global Research Analytics for Population Health. He has authored over 100 peer-reviewed scientific articles, commentaries, book chapters, and abstracts in journals including JAMA, the American Journal of Public Health, and Pediatrics. He is the recipient of numerous policy, research, and civic awards, including being named a policy innovator by the Carnegie Council, 2016 Public Official of the Year by the Michigan League of Conservation Voters, and 40 Under 40 by Crane's Detroit Business. Dr. El-Sayed earned a doctorate in public health from Oxford University as a Rhodes Scholar, and his medical degree from Columbia University as a Soros Fellow. He is a Phi Beta Kappa graduate of the University of Michigan with highest distinction in biology and political science, where he delivered the university-wide student commencement speech alongside President Bill Clinton. Please join me in welcoming Dr. El-Sayed to IHPI.
Apparently, he also cannot keep a microphone in his pocket. Okay. So it's an honor and privilege to be here. I really appreciate the invitation. As you all know, I went to college at Michigan, and so the opportunity to come back and talk about a couple of passions of mine is always a fantastic opportunity. So thank you so much for having me. I want to talk about health in Detroit generally, and talk about some challenges, some explanations, and some opportunities. We cannot talk about public health anywhere, but in particular in a place like Detroit, without talking about the challenge of poverty, and without talking specifically about how poverty shapes health across the life course. So regardless of whether or not you are an infant or a child or an adult, the impact of poverty on your life, especially aggregated over a life course, is hugely threatening. I'm hearing I should probably turn up my mic, right? Yes?
If you're behind the podium, the house system.
Okay. How about now? All right. And if we zoom in on the geography of poverty, right, we ask ourselves a question that Raj Chetty and colleagues asked, and that was profiled in the New York Times. Where is it that the poor live the longest versus the shortest lives? We can look at the map and you see that our little corner of the world here, which is kind of red, is not doing as well. So what that suggests to us is that among the poor in Southeast Michigan generally perform worse when it comes to life expectancy than the poor in other contexts. And if you were to look at where the poor live the longest versus where the poor live the shortest, you can see here that Detroit makes both shortest lists. Among men and among women, you can see that the life expectancy of the poor in Detroit is particularly low relative to places like New York City, where it's quite a bit higher. So if you make below $28,000 for a family of four in New York City, the life expectancy among a man in New York City is about 5 years higher than it is among relative to a man in Detroit. And as if to do the job for me, what the Times did in the write-up is they give you two graphs here, life expectancy on the y-axis and income percentile on the x-axis. And you can see that no matter what, income is associated with higher life expectancy. But below the 50th percentile, you start to see, when you compare New York City and Detroit, an unzipping, right? Below the 50th percentile, what you're starting to see is that those in Detroit are going to do substantially worse than those in New York City. And if we ask ourselves why that might be, it has a lot to do with the way that, A, having income can insulate you from the circumstances of place, and B, what those circumstances of place look like in a place like New York versus a place like Detroit. And let's zoom in. When I left New York City, I was at Columbia University, and my colleagues told me, look, Abdul, you could learn a lot from what we're doing in the Bronx. And what they're speaking to is the statistical reality that that the conditions in the Bronx look statistically a lot like the conditions in Detroit. So what you see here is the segregation, owner occupation of housing, education, employment, and poverty. And what they're speaking to is the argument that, in fact, if you look at one poor context, you have looked at all poor contexts. But I just want to go a step further. This is what the Bronx looks like from the air and what the Bronx looks like on the ground. And I want you to pay attention in particular to a couple of features of the Bronx on the ground. You see here a whole lot of businesses, right? Because even if you are poor, you literally live on top of many other people, and even if they don't have the same kind of disposable income as you, right? Your capacity to concentrate limited disposable income allows you the ability to attract economic resources like businesses. I want to compare that to Detroit. This is what Detroit looks like from the air, and Detroit on the ground. It's a fundamentally different type of context. So I want to show you Detroit in 5 maps. Why is it that we have this unzipping when you compare the Bronx, which is the poorest borough in New York, relative to most of the neighborhoods outside of downtown and midtown in Detroit? First, we know that Detroit is a very poor city. I already showed you that in a bunch of graphs, right? What you're seeing here is the distribution of poverty across the city of Detroit. But it's not simply about poverty. It's actually the fact that poverty manifests itself on a particularly poignant geography. Here you see you could fit all of Boston, San Francisco, and Manhattan in the city of Detroit and still have room left over. So you're talking about poverty in a huge city. In a huge city that's relatively empty. What you see here is vacancy in Detroit, not since 1967, but over the last completed decade, between 2000 and 2010. And so you have poverty in a huge city that's relatively vacant. And then what you see here is car access in Detroit relative to the rest of Wayne County. Now, the tragic irony in the city of Detroit, right, in the Motor City, is that very few people have a car. That's compounded by the fact that who built Detroit? The automotive industry. So when they built Detroit, did they invest in light rail and public transportation? No. They wanted to demonstrate how Detroit could be a model for how the car was going to fundamentally revolutionize American life. So what do? You disinvest from light rail, you disinvest from public transportation generally, and you build highways. Where do you build highways? You don't build highways where rich white people live. Generally, you build highways where poor black people live, because the political cost of zone clearance is a lot lower. And so what you see here is a map of redlining in the city of Detroit circa the late 1930s. And what it shows you is where poor blacks could live in the city relative to others. And where do you think they built I-75 and the Lodge in 96 and 94? And so we have this challenge not just of poverty, but poverty and racism manifest on a very particular kind of geography. You have poor people in a huge city that's really empty and nobody can get around. That's the challenge of Detroit. That explains the unzipping of these two curves with life expectancy below the 50th percentile. What it is that we do at the health department? Well, public health is what we as a society do collectively to assure conditions within which people can be healthy. It's what we as a society do collectively to assure conditions within which people can be healthy. And I want to highlight a couple of aspects of that for you. First, it's about context. It's about conditions. It's about the places in which people live, learn, work, pray, and play. And it's about groups of people, not just individuals. You are not doing public health if you treat many patients at one time. If you do the aggregate of medicine, you're not doing public health, you're just doing the aggregate of medicine. Right? Because public health is about context and it's about populations at a time. And lastly, it's about health promotion rather than disease cure. It's about maintaining and improving a level of health Not after people have already gotten sick, but where folks are in the first place. So I just want to sort of illustrate how it is that we think about public health via these 176 androgynous blue people. Okay? So imagine you wanted to prevent disease in these 176 androgynous blue people. You might want to ask yourself, what are the things that may make them sick? Let's say the disease we're talking about is cardiovascular disease. Okay? What are the things that are going to make them sick? You might say something like hypertension, which is blood pressure greater than, it depends on what the guideline is today, right? It's greater than something, right? And it's probably greater than, we'll just say 140. So those who have a blood pressure greater than 140 are now considered exposed. They're the folks who are at high risk. So age this population out, and you see something that looks like this. A couple of observations here. First, disease is more common in those who are high risk. That's the definition of high risk, right? However, is disease relegated to the high risk? No. There is disease among those who are not high risk. This is the Uncle Joe problem. So the Uncle Joe problem has two manifestations, and both of them end up in somebody calling me a liar. The first is the Uncle Joe problem of, my Uncle Joe smokes like a chimney. He's 95 years old, you're a liar. The second is, my Uncle Joe runs marathons, literally only eats kale, and just dropped out of a heart attack at 56, you're a liar. Right? Both of those are manifestations of the problem of risk. Right? You can see a population risk that is not determinant of any one individual's outcomes. And so it's critical for us to recognize that disease is A, more common in those with high risk, and B, not relegated to those with high risk. The approach that we would use to prevent disease in medicine looks something like this. We take our risk factor, right, and we create our little bell curve here. This risk factor is blood pressure. So we might draw an arbitrary line that sits at 140, and we say anybody to the right of that line is high risk. Agreed? What do we do for those people? Well, we have a fantastic clinical conversation with them, and we say, dear Miss Jones, did you know that your blood pressure is high? She's like, me oh my, I can't believe it. Right? And you're like, no, it's true. It is true. But the good news is there's something I can do for you. She's like, what's that? You're like, I'll put you on a diuretic, or I'll put you on an ACE inhibitor. And she's like, that's fantastic, doctor. Is that going to be good for me? You're like, well, it's good for a statistical you. I don't actually know if it's good for you, but it's good for the statistical you, so I'm going to do it. Right? And so after this fantastic, you can tell this guy, right, is getting killed on RVUs right now. Because he's actually looking her in the face, and he's actually having a conversation and showing her lab test. This is at least a 25-minute exchange, right? And for those of you who are primary care physicians, do you get this kind of time? This is how they teach you how to do it in med school. And then they're like, here's the reality of it. You're a hamster on a wheel. Go, right? So he's having this fantastic clinical conversation with her. She's feeling great about her care, as you can tell by the smile here. And at best, what we've done is we have truncated the distribution. Agreed? We truncated this distribution. We cut it off. What's the problem with this? There is unaddressed underlying risk. There were people who got the disease who were blue. They weren't green, right? But only the green folks showed themselves. So we see all of this in medicine, but we miss all of this. I want to contrast that to the public health approach. We start with the same risk distribution, and rather than drawing lines on the distribution and trying to truncate the distribution, what we do is move the distribution one way. That's because public health is about context. It's what you do in a particular place that affects everyone. If you build a market, a green market in your neighborhood, it's not just people who are hypertensive who come to the green market. It's everyone. Right? If you build a more walkable environment, it's not just people who have high cholesterol who walk around. It's everyone. So what you've fundamentally done is changed the distribution in that space by focusing on a place to get at the people who live in the place. So we see this, that goes to this, and ultimately this. Public health is about context. So there are a number of obstacles when you think about public health in a place like Detroit. Well, if health is a consequence of social well-being, then improving the health in low-income, low socioeconomic status communities is substantially harder to do. If we know that health and behaviors are reinforced in a community, well then that reinforcement is part and parcel of the behaviors we're trying to address. And if we know that vacancy, blight, transport challenges are a reality in Detroit, well then they've created the context for poor health as I showed you. At the same time though, there are a number of opportunities, and in fact they are exactly the same. Because if we know that health is a consequence of social well-being, well, if we focus on social well-being, we can improve health. And if we know that healthy behaviors are reinforced in communities, well, then communities can be leveraged to improve health. And if we know that neighborhoods are a challenge in Detroit, then if we fix our neighborhoods, we can improve health. These are all opportunities, and they're exactly the same as the obstacles. It's a matter of how you look at them, or how you color the font. If it's blue, it's good. So what are we doing in the Detroit Health Department? And I have to tell you, what will I have been doing up until today? This is the last official thing I will do as health officer, is come give a talk to you about what my very capable team is doing, and I'll explain that in a bit. We reinvigorated and reinvigorating the base of public health for the future. So you look at where we started, we had a total investment of about $1.1 million. That compares to Baltimore and Alameda County or Oakland, which are places that people like to compare to Detroit. To give you a sense of what that is, we spent about $1.50 on public health per person per year in Detroit relative to $41 in Baltimore in 2015. The good news is that that money is increasing. So we've been able to get City Council and the administration to commit to an increase in public health expenditure over the next coming years. We're also moving public health into the neighborhoods, right? Because we know that neighborhoods are a challenge. It's not enough for us to have one central health service somewhere in the middle of the city if we know people can't get around. So we have to be active out in the neighborhoods where people live, learn, work, pray, and play. And so to give you a sense of that, we're building across the city many campuses. So these are two of our campuses in Midtown, our downtown basic campus. We've got a campus in Samaritan, our Healthier Beginnings campus in North Detroit, and then we're building on the west side as well. And then lastly, it's not enough for us to catch up. If we simply just catch up to what others are doing, we will have missed the opportunity to address the challenges in Detroit as they lay. So we are reframing the Motor City. We want to be the demonstration of Public Health 3.0, how it is that a department can take the lead on coordinating, coalescing, engaging, and unifying around the work of public health, recognizing that we're not the best agency to do everything, but we ought to be the agency that helps to lead and coordinate efforts across the board. We won't be a health system, we shouldn't be the health system. What we should be able to do is focus the health systems across the goals that the city has, given the challenges that lay ahead. And we have a motivating thesis at the health department. We will leverage health to disrupt intergenerational poverty. Give you a sense of what that means. Our goal is to systematically pull down the barriers that children in our city have to being able to learn and earn like any child anywhere in the country. That's the work of the health department. And in so doing, we have an opportunity to contribute to some of Detroit's biggest challenges. And what that has allowed us to do is to frame our work around 7 critical outcomes. Okay? Those are poor infant health, because infant mortality in the city of Detroit is substantially higher. It's about twice as high as it is outside of Detroit. Okay? And the challenge with that is it's not just the tip of the iceberg of the babies who die, it's all of the other babies who are less healthy than they could have been. And the consequence of preterm birth, for example, ends up in things like earning, the likelihood of graduating high school, earnings at the age of 30. All of these things are lower among children who are born preterm. Teen pregnancy, the likelihood of dropping out of school if a woman has an unintended pregnancy before she graduates high school is about 50%. Not only that, the risk of having a preterm infant or of that infant dying is about twice to 3 times as high. Asthma, single leading health cause of school days missed. 18 days on average for a child with persistent asthma. Lead. If you get to school and your brain has been affected by lead, the likelihood that you're going to be able to make good on that education is limited. Poor vision. If you can't see the board, you can't learn the board. And so it's an obstacle to being able to learn and subsequently earn. Misnutrition. We have the tragic paradox in the city of Detroit that children are both micronutrient undernourished and macronutrient overnourished, meaning they have too little of the micronutrients that build a brain and too much of the macronutrients that build a gut. And then lastly, elderly isolation. You might say, well, if you're focused on children, why focus on the elderly? Well, we know that we have too many seniors in our community who are stuck at home. They don't have a car, they can't drive, they can't use the public transportation system, so they're stuck. That hurts them, but not only that, the best thing you can do for a young person is give them access to an older person who cares about their life. So there's an opportunity here for us to unite across generations to improve the well-being of everyone. I'm going to share with you some of what we're doing across these issue areas. we're building a program called Sister Friends. And what this is a coaching and mentorship program that leverages our best resource, which is Detroiters, to take care of pregnant Detroiters. And so what we're giving moms across our city is the opportunity to have a mentor, a coach, and a friend who can sit with them in a non-judgmental way, walk them through a very basic sense of how to do what they ought to do in terms of to have the best possible outcome for that infant, and to be a friend and a mentor and social support for them, and to connect them to the various resources that exist across our city. To give you a sense of how this works, you have sister friends and little sisters who are connected to all of the very good things that are happening in and outside the health department. And the idea basically is that one of the challenges is that 15 per 1,000 live births translates into about 150 babies who die. And if you think about it, trying to pick which 150 is really hard, but we know they're systematically more vulnerable. And so what we have to do is be able to reach deep into our community, and the best way to do that is by leveraging community members. Give you a sense of how this has worked elsewhere. In Little Rock, Arkansas, 82% of moms kept prenatal appointments. In Brooklyn, 100% of the babies were born above low birth weight. And in Racine, Wisconsin, 85% of mothers were able to stay in school or work or both. We're starting out in our District 1 and District 4 where we have the highest burden of infant mortality. What we really want to do is be able to dig deep into the district and recruit moms into our program. What you're seeing here is our program here, and it'll launch very, very soon. We're really excited about it, but you see the on the app and on the web. And we also know that a lot of moms don't have access to the internet, and so we're making this text-enabled as well. You see here the sister circle, and this woman here, her name is Catherine Hill Trujillo, and she is the founder and CEO of the Birthing Project, which created this system, and we're implementing it and rolling it out in the biggest yet program in Detroit. And our goal here is to expand from 500 to 5,000 mothers. We want to hit half of all mothers in the city of Detroit in the next 3 years. And part of doing that is being able to decentralize the program. It's one thing for us to train and administer a program. It's another entirely to give the program over to folks in the city who then build their own baby bunches and reach deeper out into the city without us having to necessarily touch it. Has anybody here ever heard of Black Girls Run? So it's an app, it's a system that basically equips folks all around the country to be able to form these running groups. And we want to do exactly the same thing with Sister Friends. On teen pregnancy, I don't know what happened to teen pregnancy. Lest I say something awkward. Let's talk about what we're doing about the challenge in the city. So we know that teenagers who live in Detroit are about 2.5 times as likely to get pregnant in an unintended way than folks living outside of the city on average. And we also know we have limited use of long-acting reversible contraceptives and very, very few physicians relative to the rest of the state. We also know the effects of teen pregnancy on graduation rates and infant mortality rates. And we know that LARCs, long-acting reversibles, are the frontline pregnancy prevention tool, although they're not used as widely as they could be. Only about 2.5% relative to 10%, for example, in Colorado. Only about 2.5% of sexually active teen women in Detroit use LARCs. So we're hitting this in 3 different ways. First, we want to make sure that doctors can understand, we work with doctors to make sure they understand how to use these and best practices around using them. So we want to put them in the hands of the doctors that are already there. The second is we want to build a campaign about this issue and be able to engage young women, parents, families, churches, schools about the importance and challenge of teen pregnancy across our city. And then lastly, we want to be able to provide them in discrete locations that are not implicitly stigmatizing. So what would it look like for us to have a preconception family planning program out of a rec center where a young woman could just as easily be playing basketball as she could be having a conversation about how to prevent unintended pregnancy? And so what we're doing is we're building a physician detailing team. We are we built a CME program for physicians across the city. We're grading doctors on their use of these. And we're engaging doctors in focus groups to understand what the barriers are to using them. And then we want to have, a comprehensive conversation with folks across the city about this challenge. And then we want to put our clinics across the city in the highest burden areas, right? And what you'll see, these black dots are doctors. So you look in either West Detroit or East Detroit, and you see how few little dots there are, and then just look right across the boundary in Grosse Pointe and Dearborn. On asthma, what you're seeing here is the asthma hospitalization rate. There's a good story and a bad story. The good story is that the hospitalization rate is going down in Detroit, which is fantastic. The bad story is it's still about 3 times as high as it is in the rest of the state of Michigan. And that's largely because the quality of air in the city of Detroit is quite poor. And that's because Detroit has long been an industrial city where you have a large number of polluters. We've done our work at the health department to stand up to many of these polluters, including Marathon Petroleum, who wanted to increase their emissions of sulfur dioxide. And we were able to stand up, work with the community to be able to convince them that it was in their best interest, in our best interest, to invest $10 million to reduce their emissions overall. At the same time, though, there's an opportunity for us to be thinking about how we signal about when air quality is particularly poor and when that may put a child at risk. And so what we're doing is we're investing in a system where we leverage inhalers that have sensors in them. Every time a child uses one, it helps to build a heat map of asthma. And then what we can do is send real-time information to families and doctors who are caring for children with asthma to help educate them about how best, in a moment, to prevent an exacerbation. All of this so you can keep a kid in school learning. We're also working with partners at Argonne National Labs to be able to put these array of things sensors across the city. So what happens now is you can have an objective air quality measurement system that's learning when there are asthma exacerbations to improve the algorithm around how to prevent that first exacerbation in the first place. So we were funded for about $150,000 through the Skillman Foundation to build this project out, and it'll get built in Southwest Detroit and also in District 3 over the coming months. On lead, what you're seeing here is lead exposure across the city. And lead in the city of Detroit is a real challenge that's largely driven by housing stock. 93% of our housing stock was built before '78 when people used lead-based paint. The story that we've heard out of Flint is a very different one about piping and about changing water and changing pH. That's not the challenge in most of the country. In most of the country, you have a story like Detroit where you have exposure in the home because of lead-based paint in the home. So what we're doing is we are building a program called Lead Safe Detroit. And what it does for us is it puts everybody in one room to case manage every single case of elevated blood lead in the city every month. More than that, it allows us to articulate and understand the opportunities that we have to use data and alignment and project management tools to understand where the holes are. What are we not providing to kids and what can we provide? So what we want to be able to do is make evidence-based decisions, target in our outreach, and be able to think about potentially providing mobile services in very micro-located places where kids are most likely to be affected. And so we're building a comprehensive system that engages educational support and policy support and legal support to provide families and children with the best possible opportunities to both prevent lead exposure and, in the setting where it happens, mitigate. On vision, what you're seeing here is statistics about the number of children who test for screening disorders in the city of Detroit. It's about 6% of kids, right? And that's 35,000 kids a year who are going to be tested and found to have abnormalities. Now, 28% of them are not going to get glasses, meaning they're going to come back next year and they're still going to test for the same abnormalities. And what the problem was is that we would have our apparatus, we would screen, we would send information home with the family, and those kids wouldn't necessarily get a pair of glasses. There's a lot that has to happen to get from screening to a pair of glasses for the kid. So what we tried to do is cut out the middleman. So what we're doing now is we're partnering with a nonprofit called Vision to Learn, where we can provide an on-site optometric exam and then deliver glasses to kids in the city. So we will deliver, we've already delivered 1,000 glasses since October, and we will deliver a pair of glasses to every kid in the city of Detroit who needs a pair at school. I'll leave you with a parting thought. I resigned my job last Monday, and I resigned my job to do this thing, which a lot of people are saying is far too audacious and that I should think about an alternative career move, and I'll be running for governor. And the reason I'm running for governor is because the values that brought me to medicine have a lot to do with the way that Rudolf Virchow thought about medicine. And he says, medicine is a social science. And politics is nothing else but medicine on a large scale. The physicians are the natural attorneys of the poor, and social problems fall to a large extent within their jurisdiction. Everything I've shown you has to do with us answering a call to deal with the consequences of a whole subset of policy that has created the circumstance within which we sit today. And the ability to do that work is founded on a set of values. We have to believe that we care fundamentally about our most vulnerable. We have to believe that equity is a challenge unto itself and something that we should care about unto itself, and that evidence and science are a good way of making decisions in a complex world. And if you look, whether that's in Lansing or in DC, those values are under siege. And if we believe in a government for people and by people, then there is a responsibility for people who believe in these things and have actualized these things in their work to stand up and be a part of government. Now, oftentimes it's easy for us to hide behind a sense of medicine and public health as these sterile things, right? We treat them very sterilely. What does the science say? And in the end, if we don't believe in science, it doesn't matter. If our society doesn't say that science is the right way of handling a problem, or doesn't say that we actually should care about the well-being of the poorest and most vulnerable in our community, then it doesn't matter. And so I was a public health scientist. I, for the last day, am a public servant working on public health. And I do hope that as I move forward in public service, that I will take the ethos of public health and medicine to where we can actually set agendas around the values that have brought us all to the table. So with that, I leave you. Detroit hustles harder and heals harder. I appreciate the opportunity to speak with you. Thank you. I presume there's a set of questions. He's already got a mic. Oh, he doesn't have a question. No.
Okay, well, congratulations on that announcement, and look forward to seeing how that proceeds. Have you already taken the official steps to all that sort of thing? Okay, congratulations. My question is, I'm an economist with the biases that an economist has, but interestingly, you stated my bias to begin your presentation, which is that you have to look at poverty. And so it's kind of a chicken-egg question, which we know what comes first. And are you here to improve our health, or are you here to improve our economic status?
I do not believe that those questions should be mutually exclusive. I do believe that systems matter, and systems often suggest to us that the challenges that we face have a lot more to do with feedback cycles than they do with any one starting position, right? And if you think about poverty and public health, there is very clearly a vicious feedback cycle between poverty and public health. Poverty shapes public health in real ways, and poor public health shapes poverty in real ways. What we wanted to do as a health department was interrupt the arm between poor health and poverty. Because as a health department, our effector arm is public health, right? But it takes doing both, right? It takes creating the kinds of scenarios, opportunities, policy contexts that ultimately invest in people. Because frankly, if we stop investing in public education systems, we do everything we can to address asthma and keep kids in school, address the vision challenge and keep kids able to see the board, and address the fact that, that many of our children get to school in the first place with a brain that's been poisoned, right? Even if we do those things and the education system cannot sustain and cannot train our kids for the next generation of jobs, it doesn't matter. It takes both of these things at the same time. And so I think that we oftentimes assume that the scope of our agency is limited to a thing that we think we can do. And my argument here is that the scope of our agency is in fact everything. That also makes it the scope of our responsibility. And for that reason, I think you're absolutely right. Poverty matters. Poor public health matters. Both matter. And we have to do both at the same time if in fact we want to address the challenge. I realize for me, if I was to stay in this job, right, I've been here for a relatively short time, a little bit less than 2 years. But if I was to stay in this job, I would be playing defense against the cuts that would come in all of the other areas around poverty policy, right? And in the end, as working within a health department, as important as that is, and as proud as I am of this work, the capacity to truly solve the challenges for that little 3-year-old kid in Detroit who I think about every time I think about our work, that's limited. And those kids deserve better. And those kids are not just kids in Detroit, they're the same story, right, as what happens in Owasso or Ontonagon County in the UP, right? It's the same story. And I think oftentimes what many of the politicians of the day have done have told us that there is this zero-sum game between poor and working people in Detroit and poor and working people in other parts of the state. And in fact, they are in much the same boat, and it takes us investing in them, all of them, in a united way that actually, I think, allows us to make some headway.
Thank you very much for your great words and great work. I work for the Washtenaw County Health Department, so we work together on various things. But being that you've only been with the health department for a short time, and you're kind of come in, now you're going out, I'm just curious about kind of your lessons learned. What kind of surprised you coming into the health department? Maybe in terms of challenges you didn't predict that were there, but just kind of as you reflect on a pretty intense 2 years, what are some things that surprised you in a good way and some in a bad way?
Yeah, I think public health is a fantastic framing for a number of challenges that we face society-wide. And being able to frame something within that perspective, you can create action in ways that potentially otherwise you might not be able to. And I think that is critically important for folks working in public health to remember, is that you have this public health cudgel, right? And the minute you see a problem that could be a public health problem, you bang it with the cudgel. And it attracts other folks to think about the problem too. I think the other challenge with that is that public health has been fundamentally disinvested from for a really long time. And as my economist friend would remind us, the role of government fundamentally, even if you are a conservative or a libertarian, is to solve collective action problems, right? Is to be in the position where a market cannot be given an answer to a question on its own. And the thing about preventing disease is that it's really hard to monetize, right? It's very, very hard to say who wants to pay for a disease that didn't happen. And so markets are great for a lot of things. Like when I went shopping and bought my coat, I'm really glad there was a market for it because I could pick what I wanted and decide what I wanted to pay. And right? But when it comes to preventing disease, you can't really do that in a market. And if we continue to make the argument that in the end, government should be a business, right? i.e. all of the aspects of business applying, meaning that markets are the way we solve everything, and that those who have the money control the market, we will fundamentally miss out on opportunities to focus on the well-being of the most vulnerable in public health. And so it takes folks who believe in public health not just to articulate the ends of public health, but to articulate what public health would mean for our society and what kind of society it is that would invest in public health in some real way. And I think oftentimes because we have been so focused on a sterile framing of public health rather than articulating the fact that public health is political like everything else. If politics comes in, every time you have to make hard decisions about limited resources, well, then public health is political because health is a limited resource. Not everybody gets to have it. And so when we make decisions about who does get to have it, right, at that point we have to be honest about the fact that if we leave it to a market, only the rich will have it. And so we have a responsibility to assuring that there is some sort of equity in the way that we divvy this scarce resource and make it less scarce. And I think sometimes when you just frame on public health, rather than appreciating the bigger political context and narrative within which we work, we miss that opportunity.
First of all, thanks a lot for being here. I really enjoyed this. I was wondering if you could talk about some of the challenges you faced organizationally working in the city of Detroit in starting a new department that had been privatized, and then just your experience going about to build a coalition to increase public health funding overall.
I think there are really three things that come to mind. The thing about success is that success breeds success. And if you haven't had success in a while, it's really hard to believe that you can have it. And so one of the hardest things that we did was to emotionally and socially reinvigorate the department. To be able to say that in fact this is a department with deep agency to accomplish real solutions for real people who fundamentally deserve better. And that, I think, was the biggest challenge for me. It was my biggest leadership challenge, is to say, you come into a department that has been gutted, you just got your bearings back, and to say, we will accomplish way more than we believed was even possible. And we will, solution after solution, deliver to the point where solutions become norms. And that becomes our culture. And I think for me, it was fundamentally about being able to take the blame for anything that went wrong and deliver the victories to everyone else. I think great leaders can do that, right? They stand in when it's hard, and then they deliver the victories to the people around them. And it took a lot of that, sometimes making a big deal about something that was really small, just so that the team could see it and say, hey, we did that. And you're like, yes, we did it. We did that, and that's pretty awesome. Look at what we can do. The second piece was being able to organize in the setting of very, very low resources, and being able to make, in a lot of ways, something out of nothing, and in part to be able to triage. You can talk about any challenge in the city of Detroit, and it's among the worst in the country. So for us, we had to really think about how we triage and how we focus. One of the challenges when you have low resources is you want to do everything, but if you do everything, you'll do everything poorly. And so what we wanted to do, right, is focus on the things we needed to do until we could grow and do everything. And we're not quite there yet, but the department that I'm leaving behind is one I'm deeply proud of. And I knew that for me, I didn't want to build a department that was based on any one person, but rather it was an institution with a culture that would persist regardless of who was at the helm. And I'm proud to say that I think we did that. We have a number of really incredible leaders who are there. 220, I think, of some of the most passionate, capable, focused public health practitioners in the country, and a department that I think is going places, and I'm really excited to watch.
Thank you.
Thank you for being here today. I understand that you had some misgivings or maybe frustrations working as a physician. I was wondering to what extent your clinical experiences have positioned you well, and what skills did you pick up in medicine that you used and which do you not? Can you talk a little bit about, for people who are early in their education, what the value of medical school was for you?
I don't believe people care what you have to say until you've listened to them and heard what they have to say. And I think the best skill I got in medical school was the ability to sit down and listen, and even in circumstances where I couldn't understand a person's experience, I've never been there before, to really work hard to try and put myself in their shoes, to understand where they were coming from, why they were coming at me that way, and to be able to truly feel some of that pain. And I believe that skill set is one that physicians, good physicians, have and cherish, and it's critical. And I think as a public servant, what your job is to do is to be able to understand fundamentally where people are in their lives, to understand where they want to be, and to do your best to correct the difference. And I think it's really hard to understand where people are in their lives if you're not willing to listen to them, right? And one of the challenges with academic training sometimes is that there is a moment where you expect that because you read it in a book, you know about it, rather than having been humble enough to hear it from somebody who's living its mouth. And so I really appreciate that. I also appreciated the ethos of medicine, where there is a sense of doctors having a sense of responsibility to their patient that is above and beyond anything else. This is my patient, and I will advocate for this patient to the end. And I think to be a great public servant, you have to be able to do the same thing with communities. This is my community, and I will advocate for this community to the end. That's the only thing I have to do right now. So I appreciate those aspects of my training. I didn't practice medicine ultimately because I was a lot more interested in why people were coming to that hospital in the first place than what I could do for them after they were there. And in a lot of ways, I looked at many of my patients who were bounce backs. They kept coming, and you cannot help but recognize that the system is fundamentally broken. When you spend 2 weeks taking care of a patient and they're back 2 weeks later. It's not good for them, it's not good for us. And I think there is a responsibility at that point to then ask yourself, well, what can I do to break this cycle? I mean that with no disrespect to folks who are practicing physicians. I think practicing medicine is both one of the most complex and important things we do as a community. But But I do think it takes a lot of us asking bigger picture questions about the system within which we practice and doing what it takes to try and interrupt it. Because right now, unfortunately, that system has been beholden to a lot of big interests, whether it be pharma or the American Hospital Association or even the AMA, who haven't always been as forthright about the well-being of our patients over the well-being of our pocketbooks. And so for me, I wanted to think outside of that box. I never wanted to be a businessman. I'm never going to be a businessman. I don't know, I hope. And I realized that in a lot of ways, if I went that route, I would be either a cog in the business or I would be a businessman myself. And that's not what I got into it for.
Thanks again for coming out here and giving this talk. I wanted to ask, being here at the University of Michigan, sometimes it's so large to keep up with everything that takes place here, especially in the surroundings. And we're supported by the state, and the university cares for the state. In your experience as being the director, could you share what some of the things that the University of Michigan, including the health system and all of its colleges and institutes, have done in turning around the city, especially in its public health? And moving forward, what are some of the things that the university could do? And then especially with your interest in pursuing governorship as well, what you would see that the role would be as well?
So I benefited tremendously from my 4 years here. You're saying it's almost impossible to keep up with all the things that the university does. I kind of think about being at a university like sitting by a river, and you could get a cup and you can put it in the river, you might drink some of the water, but you're not going to capture the whole river. Universities are, I think, among the most important institutions in American life for a couple of reasons. First, they call us to our highest ideals. I think that one of the most human things that we do in the world is teach and learn. It's a beautiful thing. Like there's not knowledge is the ultimate public good, because once you tell somebody something, it's not like you forget it. I didn't give it to you and now I don't have it anymore. It just multiplied, and that's a beautiful thing. Insofar as research universities like this one are about building knowledge and disseminating knowledge and celebrating knowledge, that's really, really critical. And I personally regret the fact that a lot of the universities, or the way that state funding has gone, it has really left our public universities to wither at the vine, rather than recognizing them as the economic engine that they absolutely are, right? And so that's number one. From a public health angle and framing, number one, you think about public health professionals across the state of Michigan, a disproportionate number of them have been trained here. Medical professionals, again, a disproportionate number of them have been trained here, and that unto itself is critical. Also, if you look at a lot of the centers here that spend their time thinking about and studying this place and health in this place, it is one of the few places that is as empowered and as local as one would want to be able to aim the resources of a university at a local problem or a local challenge. And so I'm thinking about John Ionian's recent paper in the New England Journal looking at what the economic consequences of Medicaid expansion have been, right? And being able to say, look, in Michigan, this is good policy. Whether you want to talk about public health, but even let's leave that aside, talk about economics. It's good policy. And then lastly, I think we need to, in a moment like this, it's hard to find things that are inspiring. Universities are inspiring. You walk on the Diag, it's still a really inspiring place. Remember the first day I walked on the Diag, it was like, wow, all of these people are here to learn stuff and become something, and that's amazing. And I think we need to look to things to be inspired by, and I think universities serve that purpose. And so, to me, I value what I've gotten from so many halls of knowledge, and I think we have to invest in them to allow them to fundamentally do what they will do in society, which is help us invest in people. All right. Well, I really, really appreciate the opportunity to come.